about understanding suicidality, especially in young people. Before I do that, I want to tell you a little bit of background. So this is me. My name is Dr. Laura Erickson Schroth. I'm a psychiatrist. My background is particularly in LGBTQ mental health, working with young people. So in addition to working at the Jed Foundation, I also work at the place that Amanda mentioned called Hedrick Martin Institute. For anyone who's in New York City, that's down at Astor Place near NYU. And it's a youth center for LGBTQ young people. And I've been there for about 7 years. In terms of Jed, the Jed Foundation, if anyone doesn't know, was founded by a couple who lost their son, whose name was Jed, to suicide. And that was while he was in college. And so that began our academic programs at Jed and the Jed Foundation itself. So our academic programs at Jed, we work directly with high schools and with colleges to help them assess and then strengthen their mental health and suicide prevention programs. And in addition to our school programs, we also have a number of other programs within Jed. One thing that's really helpful to know about is our mental health resource center. That's on our website, and it provides helpful information to young people themselves, to parents and caregivers, to educators. We have things like coaches' guides for high school coaches for talking about mental health with the athletes that they are working with. We also have a storytelling component. So we work with media companies to help them with depictions of youth mental health in TV and film. We have a number of campaigns. One of them is called Seize the Awkward. The idea behind that campaign, which we do with the American Foundation for Suicide Prevention and the Ad Council, is that 3/4 of young people turn to a peer for help before they turn to an adult. And so we want to equip young people to be able to talk to each other about, what's going on in their lives. So those are just a few of the things that Jed does. I also wanted to say that in coming into this, I know a lot of you are clinicians. And I worked for a long time as a direct service clinician. I worked for 6 years full-time in the psychiatric emergency room, in different emergency rooms across New York City. And I think, interestingly, I saw many, many patients who had suicidal thoughts or suicide attempts, but I actually didn't know that much about suicide on a larger scale, so on a public health level. And I think that's important to say because we don't learn that much about that. Certainly I didn't in residency. I know a lot of other people may have different training than I did. We don't learn a ton about sort of, what makes things happen on a public health level in terms of mental health and suicide prevention. I also didn't learn that much about treating suicidal thoughts. So I learned about basically how to identify them and then how to treat depression and how to keep people safe from harming themselves. So for example, admitting them to psychiatric units. But I learned a lot more once I started to dig into sort of the public health issues behind suicide. So I'm going to try to tell you a little bit about what I learned. These are some of the learning goals that I have for you today. So reviewing compassionate and destigmatizing language to describe suicidality. That's another thing that I didn't have as much knowledge about before I sort of was involved in public health around this issue. Explore how to assess suicidality. I know that comes up quite a bit in your work for many of you, not necessarily, sort of being able to, know when someone is at real imminent risk. And so that's something I think we should talk about, and examine the spectrum from suicidal thoughts to actions. So that's once you're sort of doing that assessment, where does this person fall on that assessment? And then what do they need at that moment? So first, I wanted to tell you a little bit about youth mental health and suicide trends that I had been learning about. These are some of sort of like the big national studies that we look at Jed to understand what's going on with young people. This is the Youth Risk Behavior Survey. So the Youth Risk Behavior Survey is a national survey done of high school students every 2 years. So the latest data is from 2021. And we're seeing pretty concerning trends over time, over the past decade with young people. So, we're seeing that young people are reporting experiencing persistent feelings of sadness or hopelessness, That has gone up from 28% of young people to 42% of young people. And to be specific about this statistic, they have to have reported that over the last year, they've had 2 weeks or more of feeling persistently sad or hopeless. And a lot more are seriously considering attempting suicide. In 2011, it was 16%, and in 2021, it was 22% of young people reporting that, making suicide plans, up from 13% to 18%, and attempting suicide going from 8 to 10%. So there are some concerning trends in the data. I don't know how many of you saw this, but the Surgeon General earlier this year put out a report about the epidemic of loneliness and isolation in our country. And I think this is an important time to talk about what young people are experiencing right now. So, there are wars around the world, there's violence in their schools, in their news feeds, there are movements for racial justice, and they're seeing, racial violence depicted on TV and in their news feeds kind of all the time. They're worried about the climate, and this is all while they're living their lives online, where they can get support, especially, young people who might not find enough of that in person. So LGBTQ youth of color, especially living in rural areas, can get a lot of support online, but they're also exposed to a lot of, potential negative effects of social media and online worlds. And so it really is a balance. And all of that is culminating in this epidemic of loneliness and isolation. Americans are spending less time with each other, and the decline is actually starkest for young people. So among young people 15 to 24, for that age group, time spent in person with friends has decreased almost 70% over the last 2 decades. So in 2003, young people were spending 150 minutes, so 2.5 hours every day in person with friends. And now it's only 40 minutes a day. So that's a pretty stark contrast. One of the domains in our comprehensive approach, which is the sort of domains that we use where we know that there's research behind the things that we do in suicide prevention and how we work with schools. One of those domains in our comprehensive approach is to promote social connectedness. And that's because research shows that social isolation and loneliness are risk factors for poor mental health, and not just poor mental health, but poor physical health. If you look at this, lacking social connection is, basically equivalent to smoking up to 15 cigarettes a day in terms of physical health. So isolation predicts depression, anxiety, substance abuse, suicidality, and earlier death from all causes. And on the other hand, we know social connection and community decrease depression and suicidality. So I just wanted to make that point, that young people are really going through quite a lot. And, it's showing in the suicide rates. So suicide rates have been rising for 2 decades. And we luckily had a drop in suicide rates over the last year for young people of about 8%, but that hasn't been the trend for most of the last 2 decades. These are some sort of particular statistics that might be helpful to people. Over half of suicide deaths in the US involve firearms. So a lot of what we can do, especially in rural areas or in areas where firearms are more available, is to make sure that we're in communities talking with them about safe storage and making sure that young people who might be thinking about suicide don't have access to firearms, because it really matters, if they have access in the moment. About 80% of suicide deaths are boys and young and men. And actually girls and women attempt suicide more often, but boys and men are more likely to die by suicide. And again, that's because of access to lethal means and use of lethal means like firearms. If you look at the graph on the right, this is young people and rates of suicide. And if you can see, actually the group of young people that has the highest rates of suicide by race are American Indian, Alaska Native youth. And that's very concerning, because that's a group that I think a lot of times isn't talked about as much, because it's not as large of a population. But American Indian, Alaska Native youth really need some attention in terms of mental health and suicide prevention. Some more statistics that might be helpful: rural youth have about twice the suicide rate of urban youth. A lot of that is due to lethal means and access to firearms. LGBTQIA youth have rates of suicide thoughts and attempts that are 2 to 3 times higher than their cisgender heterosexual peers. We actually don't know necessarily if LGBTQIA plus youth have higher rates of suicide deaths. And the reason we don't know that is that information isn't included in suicide death information, because we might not know when someone dies how they identified. So there are things that we still don't know, but we do know that they're attempting at higher rates. So I wanted to talk a bit about language around suicide. And actually, I was chatting with Amanda before this presentation about the fact that in addition to sort of a public health lens on suicidality, I didn't know that much about language around suicide when I was working strictly as a clinician. And I think the reason for that is that we didn't sort of talk about messaging. We talked about working with individual clients, but we didn't talk about how do we discuss these kinds of things in a public setting to destigmatize them and make sure people feel comfortable and like it's something that they can talk about. So, when we're talking about suicide, we need to be talking about it, but we want to choose our words carefully to avoid making sort of assumptions, talking about suicide in a stigmatizing way, because that means that people aren't going to be as likely to reach out for help. So, we don't want to imply that mental illness makes someone fragile or violent. Actually, if we're talking about violence, people with serious mental illness are much more likely to be victims of violence than perpetrators of violence. And using compassionate words really can help provide hope to people. Let them know that you're there to help them and you're not there to be judgmental. Sorry, I'm going to go back one slide. So this is some of the particular language around suicide and how to discuss it. So at Jed and in other suicide prevention organizations, we try to use destigmatizing supportive language when we talk about suicide. So for example, when someone's died, we say that they've died by suicide rather than some of the phrases that are more commonly used, including committed suicide or killed themselves. The reasons for that are, for commit, that can imply a sin or a crime. And killed really comes across as very violent. So we want to make sure that we're talking about these in ways that make people feel comfortable discussing them. If someone lives through a suicide attempt, we say that they survived a suicide attempt because using language like unsuccessful or failed suicide attempt implies that it would have been a success to die by suicide. And that's not the kind of language that we want to use. If someone's having suicidal thoughts, we use person-centered language. So instead of calling someone suicidal, we say that they're having suicidal thoughts or thinking about suicide. And that actually allows for change over time because suicidal thoughts come and go pretty frequently for people. And someone might be feeling suicidal and then might later not be feeling suicidal. So that the person themselves is not suicidal. They might be feeling that way. In terms of language for clinicians, I know a lot of times we hear things like suicidal gesture or parasuicidal behavior. I think it's important that we use more precise language and discuss whether someone actually had a suicide attempt. If you talk with them, did they tell you that they intended to die, or that it was something like, they were hoping actually that it wouldn't work and they would get help. So I think we need to, that kind of language can come across to patients as judgmental. We also, as I said, want to describe thoughts or behaviors as suicidal and not the person themselves. I'm going to go into some key facts about suicide. And these come from myths that we often hear. And so I'll talk a little bit about that. And you can see if this sort of resonates with what you've heard or what people have talked about who you know. So one of them, we often hear that, it's not really okay to talk about suicide. A lot of people think that talking about it is going to make someone more likely to act on it. But actually the opposite's true. Bringing up suicide with someone who's been thinking about it, through research, we can see that it often provides a sense of relief. It increases help-seeking behavior. People want to reach out for help. So it really is okay to talk about suicide, and actually we encourage it. Another is that, suicide isn't selfish. I think that's something that we hear quite a bit. People think that, Someone who dies by suicide might be acting selfishly, not considering the pain that their friends or family are going through. But what we hear when we talk with people who are thinking about suicide is they actually think the opposite. They actually think that they're a burden to other people. And that's something that allows them to think about suicide, because they think maybe actually people would be better off without me. So they're thinking in a really different way and through a lens that's very different than people who are not feeling suicidal at the time. The other thing to talk about is, and I think this is really important because what the news media shows us is very different. There actually isn't any one definitive cause when a person dies by suicide. Almost 100% of the time, there are a lot of things that are contributing, right? So we'll often hear stories in the news, for example, someone was kicked out of school or lost their job or had a relationship breakup. And the media will try to portray that as something that, that was the main cause, or the person was fine before that. But actually, it's really much more common that someone has a lot going on in their life, that there was a lot going on with them growing up, that they had, some difficult or traumatic experiences, that those shaped, some of the things that are going on in their life now. And now in their life now, there's a lot more going on than that one thing. It's really important not to simplify the narrative, and that's for a couple of reasons. One is that it really normalizes suicide as the answer to a difficult situation, and we don't want to be telling that story. It also makes people think that addressing that one thing will solve things. So, for example, you may hear, a student died by suicide, and then what the news is trying to tell you is that that's because of bullying. And that makes us think that if we just can make sure, kids don't get bullied, then no one's going to die by suicide. We do need to decrease bullying, and we do need to work on these kinds of issues, but we need to make sure that we're doing it holistically, and we're not saying that there's one cause and one thing that we can change that will, decrease suicide rates to zero. So another myth that we often hear about is that someone is thinking about suicide, that they, sort of like you can't stop them once it's something that they're thinking about. That's actually not true at all. So if someone's thinking about suicide, there really are often very effective ways to intervene. And that's because suicidal crises can be really short-lived. So suicidal crises often escalate really quickly. If you look at research, almost half of people who made a serious suicide attempt said that they first thought about making that suicide attempt within 10 minutes of making it. And over 70% said they'd first thought about it within an hour of the attempt. So that means that during an acute crisis, a person's survival might actually come down to what methods are available to them and who's around to help. So in addition to escalating quickly, suicidal crises actually can often resolve quickly, especially if someone gets help and support. So being there and being that presence to support them really does matter. The final myth that I'm going to talk about is that, some people think that if you hear someone talking or joking about suicide, that they're really not seriously thinking about it. Actually, when people talk about suicide, sometimes they're kind of testing it out, right? Sometimes they're ambivalent, meaning they might have thoughts of suicide, but they also have things that are keeping themselves alive. And so I think it's important to note that, even joking about suicide, even talking about suicide in that kind of manner really can mean something. Another context where you might hear this myth is in conversations with parents. And I've heard this quite a lot. They might wonder if their teen is making statements about dying in order to be provocative or for attention. And some people do make statements about suicide, even if they're not having actual thoughts about suicide. But the important thing to recognize there is that even if someone's not having suicidal thoughts, making statements about suicide really reveals that something is going on, right? If someone's using suicidal statements to express their distress, if that's the only way that they know to show someone how badly they're hurting, then that's really concerning. And that's a point where support is really essential. So I'm just going to take a quick water break. And we're going to go into understanding the spectrums from suicidal thoughts to plans. So I think one of the first things to talk about with this spectrum is the difference between suicide and self-harm. So non-suicidal self-inflicted injury. So suicide is death caused by injuring yourself with the intent to die. And a suicide attempt is when you harm yourself with an intent to end your life, but you don't die as a result of your actions. Whereas self-harm or non-suicidal self-inflicted injury refers to the intentional destruction of your body without suicidal intent. So it might be things like cutting yourself, burning, scratching. I've seen young people who are do head banging, things like that, to harm themselves without the intent to die. And often self-injury is a form of self-soothing, actually. It's a coping skill that someone's developed to deal with distress, and it's often linked to childhood or teenage trauma. So when someone's self-injuring, they don't intend to die, but they actually can sometimes harm themselves more than they intended, and I've seen that happen. There is also a link between self-injury and suicide, in that those who self-injure are more likely to attempt suicide. So there are a number of theories about this, but one is that people who self-injure have become used to harming themselves, which makes it easier to attempt suicide. And what's really important to know is there's really effective treatment for self-injury. And many of you have probably heard of or used DBT, dialectical behavior therapy, which helps people to find alternative coping skills that they can reach for if they're thinking about self-injury. And actually research shows that if you're in a DBT program, that's a true DBT program, for a year, more than 90% of people are able to stop self-injuring. And most of them have actually stopped about halfway through. So I'd like to talk a little bit about assessing suicidality. So these are probably terms that you've heard before as clinicians, but I think it's important to sort of go through these stages and talk through them a little bit. So, we think about passive suicidal thoughts. And these are suicidal thoughts where someone is thinking about something happening to them. So they're not having active suicidal thoughts of doing something to harm themselves. They're wondering what it would be like if they weren't there. They're thinking about going to sleep and not waking up. They're wishing something would happen. I wish I would get hit by a bus, or I wish I wouldn't wake up, things like that. Their thoughts have not progressed to the point where they're thinking about things to do to harm themselves. And for most cases of passive suicidal thoughts, that's something where you can, if these are new, you can think about, is there something going on with this person? Do I need to refer them to, further help? Can I get involved more in some way? Do I need to bring in family members, things like that? But it's not necessarily something where you need to escalate to an emergency room setting or something like that. If someone's thinking about suicide in an active way, they're having active suicidal thoughts. These are things like, things they might do to end their lives. They might be researching methods, or thinking about acquiring means, or even maybe considering suicide as a backup option. They might say, I know that if, things get really bad, I can always do X, Y, or Z, and they have in mind specifically what that might be. This still might not be a time when you need to refer someone for sort of emergency care, right? This is someone who, you talk with and you find out more about what's going on. You say, I'm worried about you. I wonder if you think that this could progress to, action, and what would it take for that to happen? Are there things that are keeping you here, that things that you're living for that you really care about? Are there reasons that you wouldn't go through with the things that you've thought about? And a lot of times people will say, yeah, I don't think I would ever do that. It's just a thought that pops into my head, and I always want to kind of know that if things get really, really bad, it's an option that I have, or things like that. And a lot of times it's not new. A lot of times people have had these kind of active thoughts of suicide for years even, and they haven't progressed anywhere. So I think asking more detailed questions is really important. Then we're getting to the point of preparation or plans. When people are buying pills and stockpiling them, or looking to buy weapons, or figuring out things like when someone else won't be home, when they're making preparatory plans for suicide, that's when it's getting to the point where you really need to make sure that that person, has a safe place to be. So, I talked about this a bit earlier, but I think it's important to point out that most suicide attempts are impulsive. They're not planned out. Certainly there are people that plan suicide attempts, but most suicide attempts are not planned. Most of them are in a moment of distress when someone is ambivalent and they end up moving forward with a suicide attempt. Often they're kind of testing the waters. I've seen a lot of people in the emergency room who took a few pills to see what it would do, that kind of thing, hoping or knowing that it probably wouldn't work. And as I said before, suicidal crises really escalate quickly, but they also can de-escalate quickly. And so I think it's important to talk about how that works. And a lot of times you can get people through those feelings, and you can get them to the other side and thinking about, how they're going to plan for the future. So, I wanted to give a little bit of a public health scope on suicide in the US. I think this is also something that I didn't quite understand. I understood a bit because working in the emergency room, I saw a lot of people who came in with suicidal thoughts, and I saw a lot of people who had attempted suicide. And most of the people, luckily, who attempted suicide didn't die by suicide, and that's great. And one of the reasons for that is that they didn't use lethal means, because lethal means can really change the game. So if we're talking about numbers, about 12 million people a year in the US have thoughts of suicide at some point over the last year. About 3.5 million make a plan for suicide, about 1.7 million attempt suicide, and then about 48 or 49,000 die by suicide. So I think this is helpful. This was helpful for me in my mind to frame that there are a lot of people walking around with suicidal thoughts, and we can be the clinicians that help them with those. And we don't necessarily need to triage on to someone else, because most of the time, most of those people are not going to act on their thoughts. I also wanted to talk a little bit about mental illness and suicide, because I think there are some myths around this too. When they've done studies of people who died by suicide, fewer than half of them actually had a diagnosed mental illness at the time of their death. There's a lot we could say about that. Certainly, there are people who had undiagnosed mental illnesses at the time of their death. But, I think what the research shows us is there are actually a number of people who die by suicide who don't have a mental illness. And so suicide is not necessarily always about having a mental illness. When we do talk about mental illnesses, the mental illnesses with the highest rates of suicide might be surprising. This was surprising to me when I first learned about it in residency, that actually psychotic illnesses are the mental illnesses with the highest rates of suicide, things like schizophrenia. After that, bipolar disorder, then actually substance use disorders, and then depression. I think most people think depression is the one with the highest rates. And, again, some caveats about this. I think, one of those is that psychotic disorders, though they put people at the highest risk, are much less common. They're rare conditions. So about 1% of people in the US and across the world have schizophrenia. And so among those who die by suicide, they're more likely to have had a depressive disorder, even though it's more common within people who have schizophrenia. Alcohol and suicide is actually also a really interesting topic. A significant portion of people who die by suicide have alcohol in their systems. Typically, the number that you hear is around a quarter of people. And, it's not totally clear whether it's because, people with alcohol use disorder have higher rates, which they do, at least through the research, that we have, but also because sometimes people use alcohol to sort of get up the courage, they call it, to have a suicide attempt. And so, there are some interesting intersections between these things. I wanted to talk a tiny bit about common suicide risk assessment tools. These are two of the most common. One is called the Ask Suicide Screening Questions, the ASQ, and the other is the Columbia Suicide Severity Rating Scale. I'm guessing that a lot of you have seen the Columbia one. It's very frequently used. The ASQ I really like for young people was actually developed in pediatric emergency rooms. It's a little simpler and it's a little easier to use for young people. The Columbia one can be quite cumbersome, especially when working with young people. And I think it's important to talk about, these kind of screening tools in general. One thing that's really important is that if you use a screening tool, you have to be ready to act on whatever comes out of that assessment. So you want to make sure, obviously within clinics, you will have people to respond to that, but you want to make sure you have a protocol in place, and that things are set up so that if someone does respond to one of these in the affirmative, that you know what the next steps are. And I also want to talk about that there are really effective treatments for suicidal thoughts. And this is also something I didn't learn a lot about in residency. Like I said, I learned about, people have depression and then they feel suicidal. And so we need to treat their depression. And if they're feeling, they're having, pretty severe thoughts of suicide, or they had a recent suicide attempt and we're really worried about them, we have to put them in the hospital. But there are actually a number of effective treatments that are really underutilized. A lot of us know about DBT, and we know that to stay true to the DBT model, you really need a pretty, you need a setup that includes group therapy, individual therapy, a psychiatrist on site. There's a lot to sort of make up a DBT program, and that's because it has group therapy, individual therapy, psychiatry, and it's all contained, right? That person is being seen separately from any long-term providers that they might have, and then they go back to their long-term providers. So it's really a program if you really want to make it work. And for anyone who doesn't know that much about DBT, it's a group-based skills training program. It's made up of 4 key modules: mindfulness, emotion regulation, interpersonal effectiveness, and distress tolerance. CAMS is one that I think a lot of clinicians haven't heard of, but it's becoming more popular, and I think that's good. It's an individual form of treatment that focuses on collaboration, and the collaborations between the client and the therapist, so that the client can really lead in identifying their drivers, things that make them feel suicidal, reasons for living, interventions that might help them. And so it's really focused on suicidality itself. There's also CBT for suicide prevention. So many of you have probably used CBT for anxiety or OCD or depression, and there's actually a specific form of CBT for suicide prevention. And the idea, of course, behind CBT is restructuring your thinking to change your emotional state. And that's what CBT for suicide prevention does, specifically about suicide. So the last one I'm going to talk about is safety planning. It's actually not a particular form of treatment, right? It's more of a tool that we use alongside treatment. And we also shouldn't use this as sort of like a contract. I know that's been done in the past, where someone will say, like, I contract not to act on my suicidal thoughts. That's been shown not to be effective. But what is really effective is working with someone to create a safety plan. So in terms of safety planning, again, it's not a treatment, but it is a tool. And what it does is you list out with the client, warning signs that they know that they're getting to the point where they're going to feel in real distress, internal coping strategies, things they can do, whether that's writing, listening to music, those kind of things. Friends or family that they can reach out to, professionals that they can reach out to, and then, of course, crisis line information. And you might want to put really concrete resources in a safety plan, things like the name and phone number of your doctor, the name and phone number of your school counselor if it's a young person, the 988 suicide and crisis line, the text line, info to reach a parent or guardian if you would like someone else to reach out for you. A lot of times people actually also add affirmations to suicide safety plans. Things like, I have support and someone is going to help me. I feel this way and it's only temporary. I can call on people to support me. A hope list, things that they look forward to, events that they, are wanting to participate in, so that they can really go back to that in moments of distress and, think this is a list of that I made when I was feeling better, and these still ring true, things that I really want to accomplish in life. Sometimes people ask, where do you keep a safety plan? So in the past, it was on a piece of paper, and some people still do that. But also for a lot of young people, they'll store it in their phone. And they'll maybe even share it with someone. So they may not even get to the point of acting on the things in the safety plan and going forward with them, but they'll maybe pull it up on their phone and they'll just say, I feel really overwhelmed. Can I share my safety plan with you, and they'll show it to someone, and that person can help them to do those things, or to seek out help. So, I'm done with the formal presentation. I'm looking forward to Q&A. These are some resources that we wanted to provide you in case you don't have them. You may have many of these. I think probably most people in this Zoom room know about 988, which is a suicide and crisis lifeline. It's about a year ago started to be a 3-digit number that you could text, chat, or call. Some additional resources, I'll go back one, the crisis text line. For young people who are LGBTQIA+, the Trevor Project, they also have text, chat, and call. Trans Lifeline, Asian LifeNet hotline. There are a number of different hotlines run by different groups. We can provide this with you afterwards, but there are a lot of national mental health resources for specific groups of young people. And I'd just like to send a big thank you out to everybody that I can't see. Thank you for, attending this. And, if you need further resources, feel free to reach out to the Jed Foundation. And just so glad to be here with you.
Thank you. Thank you so much. That was wonderful and really informative and helpful. We had so many people commenting in the chat, just commenting how helpful all of this information has been. I encourage people to continue to write questions in the chat. A couple have come through during the course of the presentation, but as you're thinking of more now, feel free to add them in either the chat or the Q&A, and we'll get to them. So I'd love to start fielding some questions to you, Dr. Erickson-Schroth, if you don't mind. One of the first ones that came in is, hi, I hope this is appropriate. I'm seeing a buzzword of unalived themselves. Is this appropriate?
Yeah, so I'm guessing that was from a young person who's using social media, or maybe reading about it in an article about social media. There are a lot of those kind of words that young people use to search when they're trying to find information about mental health or about suicide, or to see what other people are talking about related to that. So there's unalive, there's one sewer slide instead of suicide. Young people talk about grippy socks, which means they'll say something, I went on a grippy sock vacation. They talk about permitting suicide, like Kermit the Frog, because there was a meme around that. They use all of those as search terms to find information about suicide and find other people who are talking about it. And I think it's really great that you asked, because I think it's important to talk about this kind of thing, and we should know the language that young people are using. And social media companies are really trying to cut down on the use of those. So when people are using those, they're trying to flag those posts and take them down if they have to do with active thoughts of suicide or methods of suicide, things like that. So I think the most important thing when you hear something like that, if a young person's talking about that kind of thing, is to just be interested, ask them about it. Like, how did you hear about this term? Who's using it? Where did you see it? And then ask them, why they're looking into those terms, whether they're, it's because they're thinking about suicide, or a friend was talking about it, or something like that. But yeah, I think it's a great question, and it's great for us to be aware of these kinds of things, to be curious with the young people that we're working with, and ask them, how they've run into these terms.
Another question came in asking, at which, if any, of these phases do you contact emergency care? And I'm guessing that we're referring to the passive, active, and preparation phases. Which, in your opinion, if any, would you contact emergency care to intervene?
Yeah, it's a great question. And I think that the answer is it depends. And what it really depends most on is that young person, right? So I have a lot of young people who I work with who have chronic suicidal thoughts. And, it's usually the scariest when you first meet them. And it's the first time you're meeting them, and you don't know sort of what they're like at baseline. And so you really, the first time you meet someone, want to ask them lots of questions about if they're bringing up, current suicidal thoughts or recent suicidal thoughts, to get a sense of whether that's chronic for them or whether anything has changed. If you've been working with a young person for a long time, any kind of change, I think, should be something to pay attention to. So if you've been working with a young person who's never had suicidal thoughts before, and now they're having passive suicidal thoughts, for that young person, it might be important to talk with them about, involving parents or caregivers, about, making a change in your treatment plan, those kinds of things, because for that young person, that's a really big change. So I think it's really about knowing the young people you're working with. Certainly anyone who's making, plans, preparatory action for suicide, that's a time to escalate. But even young people who are having active suicidal thoughts, thinking about different, ways of dying by suicide, that might be chronic for them, and they might be able to talk with you about all of the reasons that they wouldn't move forward with that. And you've heard them say the same thing, the week before you were meeting with them, and the week before that. So you're really looking for change.
I think it's such an important point because, and I think as a mental health field, we're all getting to a place where we're understanding that we can, for certain patients, certain clients, treat individuals who are chronically experiencing suicidal thoughts in an outpatient setting. Going to an ER, once a week has its own implications as well for mental wellness. And so I think that's a really important point to remember.
Yeah, and I think what you're saying about ERs is a really good point too. Having worked in ERs for a long time, unless someone is, at imminent risk of dying by suicide, they're likely not going to be admitted. And so, certainly if you're concerned, bring them to the ER. But if you're, pretty sure that this is not someone who's going to be admitted, it can actually be, pretty detrimental to that young person's experience to go through being, in the ER. There are really long wait periods to get inpatient beds, and most people actually won't be admitted to inpatient units. They'll spend a few days maybe in the emergency room, without their cell phone, without any friends or family around, in a hospital gown, and that can actually make people feel worse. They want to be connected to their friends and family. They want to be connected to you, being able to keep meeting with you. And so I think that's a really good point, that, emergency rooms really should be used, only for emergencies for that reason.
What do you think of the language "died of suicide" or "died from suicide"? It feels better to me as a lost survivor because it's less about how and more about their cause of death, just like when we talk about other causes of death.
That's a good question. I don't know that I've thought about that enough. I would welcome perspectives on that, the die from or the die by. I think that makes a really good point, that we talk about dying from cancer. We don't talk about dying by cancer, for example. I'd be interested to talk more about that.
We discussed that also before we have done this on this Zoom as well, about how it's so important to always be curious about language, and especially listen to people with lived experience in terms of understanding language. Language is important.
Yeah. That's interesting. If anyone in the chat has any articles or things like that to point us to, please do.
Could you please share some differences that come with suicide among youth versus adults? For example, would you talk about it differently? Is time to attempt longer, shorter, etc.?
Yeah, that's a great question. So I was talking about sort of ambivalence and impulsivity, and as would be expected, young people are more likely to make impulsive suicide attempts. So they're much more likely to attempt suicide without planning and thinking about it, which for us who work with youth is actually a good thing, because they're less likely to use lethal means than, older adults because they haven't done as much planning most of the time. They also are much more likely to attempt suicide than to die by suicide than, older people. And that's exactly for the reason, that I talked about, that I think more suicide attempts are ambivalent or impulsive.
Are there any new medications that have been proven to reduce suicidal thinking in young people around puberty when this can increase suicidal thinking / depression?
Yeah, I think people are probably talking about SSRIs and sort of the labels on those. There aren't a lot of great studies recently on medications or other treatments like ketamine, for example, or things like that in young people. Most of the studies are done in adults. So, I don't think that, I don't know that there's necessarily anything new to talk about in this webinar, in addition to things that have been out for a little while. Certainly in adults, the things that they're, looking into right now, ketamine is one of them. They're doing a lot of trials of ketamine in, emergency rooms. I don't know if I talked about this at the beginning. I am, to be clear, not actually a child psychiatrist. I work with teens and young adults. And so you might actually want to have a child psychiatrist who has like a really good understanding of the pharmacology and the trials around psychiatric medications for like younger people under 18 to do one of these seminars. I think that would be fantastic.
What are some good things to say to someone to get them through a suicidal period until it abates? Someone who is, say, in stage 2, so I guess more active.
Yeah. I mean, I think there are a lot of different ways that you can approach that. The first is just listening and being supportive. And that's probably the most important. Usually when someone's going through a period of distress, what helps the most is just to be there, to know that someone is, in the room with them, curious about their lives, wants to know what's going on, asking them if there are things that they know would be helpful that you can provide support for. I think beyond that, as clinicians, and I wouldn't necessarily recommend, all these kinds of things for the general public, but I think for clinicians, we really can do a little bit more beyond that, because we sort of know, in terms of background about what helps people with suicidal thinking. So we can talk about, together we can make a list of the things that, you're looking forward to, and that, hopes that you might have for the future, things that sort of connect you to living. The same kind of things that you're doing when you talk about putting together a safety plan, thinking with that person together collaboratively about the things that help them to stay connected and want to be alive.
This is a really important question and very specific. How would you deal with a trans youth who is dealing with constant suicidal ideation and who is not yet able to begin hormone therapy or the transition process?
Yeah, it's a really good question. I've worked with a lot of queer and trans young people, and I think this comes up quite a bit, where there's just barriers to, doing the things that they know are going to make them feel better. And sometimes that has to do with parental consent or caregiver consent. Sometimes it has to do with, the age that whatever the procedure is allowed where they live, that kind of thing. I think it's a lot of being in it with them, right? So not sort of like not sort of disregarding the kinds of feelings that they're having or minimizing them, like really recognizing and being in there with them with what's going on. Like, this is like, I can understand how this would be so hard to be in the position you're in, where that there's something that you feel would really help you and you're not able to access that. So let's think together, again, collaboratively. Let's think together about what are the things that you can do, that you do have control over, that I can help you with, that other people in your life can support you with, that can help you get through this time period until you're able to do this thing that you need to do.
Another pretty specific question that's coming in: client facing incarceration and reports will kill himself, afraid he will be raped or murdered in prison, facing many charges, no history of suicide attempts, but is presenting in a way that's very concerning and has a court date that's imminent. How do you address a situation like that?
Yeah, I mean, that sounds like a really scary situation, especially for this young client, like to be in this position of like, obviously our, um, uh, criminal system is not set up while you're waiting for trial to be a safe place for people to be, whether they're adults or young people. And so they're really facing something kind of, really, really objectively difficult. I don't know the circumstances exactly of this situation. It sounds like maybe this person is not necessarily going to be in jail or prison until their trial, from the way the question was worded. I think if you are concerned and they're making these kinds of statements, you really have to, again, talk with them in more detail. It sounds like it's possible it might be conditional, meaning like they aren't planning on acting on anything until they find out that something is going to happen, that they've lost their case or whatever it is. And so it really is talking in detail with that young person and really getting to what's actually going on. Are you thinking about doing something to hurt yourself, before you even go to trial? Like how exactly is this working in your head? Because sometimes these kind of things are conditional, and where you really have to worry about someone is when they're right about to find out this really difficult thing.
I'm going to do one more. I know we're up against a time limit here, but there's another specific one that I think is an important one as well.
Okay.
Are you able to speak to suicide in the context of autism spectrum disorder? Specifically, I'm wondering about the social skills piece, as sometimes young folks with ASD might express suicidal or other types of self-harming behavior without proficiency in essentially, reading the room, language, obviously, all of those associated traits.
Yeah, I mean, I think, I am not a specialist in ASD, and so I'm not going to say anything in particular. I do think that obviously there are different struggles and there are different things that people go through, and people with ASD may sort of express themselves differently, and I think that would be another great topic
Great.
to have. Yeah.
Express themselves differently, but also process information differently. And just like when, if you were working with a 8-year-old versus a 18-year-old versus a 35-year-old, I think language does change, and the way that we utilize interventions change, and certainly with certain diagnoses as well. I was thinking the same thing with somebody who's maybe actively in a state of psychosis or experiencing positive symptoms of schizophrenia. You would talk to them in a different type of a way as well.
Yeah, for sure. I mean, I think that, like, this is obviously really complicated and we're just scratching the surface. But I think it's really cool that all of these questions are coming up, because that means you're thinking about your individual clients and the people that you work with and really care about them and want to think about them really as individuals and the way that these kind of things affect them.
Yeah.
So yeah, interested to hear what other webinars you have.
Yeah, absolutely. Thank you. I wish we could get to everything. We'll have to do another presentation as like a continuation of this one as well. Thank you everybody for participating so actively in the chat and in the Q&As. It's always more engaging when everybody's involved, and clearly this was a topic that was important. So our next CE event will be coming up on the 19th in partnership with Columbia University's Clinic for Anxiety and Related Disorders. And we're going to be addressing specifically school anxiety and avoidance. In terms of CEs for this, be out on the lookout for an email following this presentation, which will sort of explain what to do for CE credits, etc. Thank you. Thank you so much, Dr. Erickson-Schroth, for the presentation and for being here as well.
Absolutely. Thank you so much, everyone, for coming.